Thank you, Professor Sama, for this nice presentation. Now, Dr. Amr Aboelrous, who will talk about Lerich syndrome in youth.
Good evening. Great thanks for kind invitation for Professor Nasr and as a member of Egyptian Vascular Club. My talk today about Lerich syndrome in youth in case scenario. Lerich syndrome comprise pelvic and lower limb chronic ischemia caused by aortoiliac occlusive disease affecting distal abdominal aorta, iliac artery, and femoropopliteal bypass, femoropopliteal segment. Lerich syndrome present with triad of claudication, impotence, and absence of femoral pulses. Lerich syndrome was first described in 1914 by Robert Grumman, and in 1940 the trio of symptoms was documented as syndrome by Henry Lerich, now known as the father of Lerich syndrome. Differential diagnosis of the Lerich syndrome, the arterial dissection, particularly in iliac artery, cause claudication or absent femoral pulses, mimicking the symptom profile of Lerich syndrome. Also, mid-aortic syndrome, but it occurs at renal level in aorta, with involvement longer segment, usually a much younger patient, usually from 10 to 30 years old. Lerich syndrome classified according to anatomical location of the atheromatous lesion. Type 1 confined to distal aortic segment and common iliac artery. Type 2 increase the extension of the lesion to the external iliac artery. Type 3 aortoiliac segment and femoropopliteal vessel. Lerich syndrome etiology, the main etiology is atherosclerosis. Also, vasculitis and thrombosis may cause the same in many, in little percentage of patients. However, the prevalence of peripheral arterial disease increase in aging population. The prevalence of peripheral arterial disease is 14% for patients older than 69 years of age. Patients with peripheral arterial disease may asymptomatic in 10%, so exact prevalence of the incidence of Lerich syndrome are unknown. Additionally, aortoiliac occlusive disease is more prevalent among males and non-Hispanic black race. A unique triad of symptoms, erectile dysfunction, diminished pulses, thigh claudication appear in patients between 40 and 60 years. Lerich syndrome are reported at younger age. Some authors reported that Lerich syndrome usually affecting younger between 30 to 40 years male. The case scenario today, male patient aged 35 years old presented at general surgery clinic with right lateral toe infected wound, not respond to treatment. Patient complain of severe pain. Condition started by trauma 3 weeks ago. Patient not known to be hypertensive nor diabetic. Also, the only single patient have smoker for more than 20 years old. Patient started systemic antibiotic, debridement done by general surgeon, then daily dressing occur. At follow-up, the condition get worse with gangrene of edge of wound, with no response of antibiotic and analgesic. Is this a patient managed by the proper way? What is the problem? What is the missed step? Classically, when the patient referred to vascular clinic, we step our patient, we start with history taken, pain increase at night with elevation of the leg and decrease by both his leg independent position. Patient had a trauma 2 weeks ago in little 2 with severe pain and unhealed wound. Patient had erectile dysfunction 1 year ago. It is the first part of our triad of the Lerich syndrome. Patient also complained of pain in the whole leg 1 year ago, and patient on opioid, tramadol daily. Pain started as a cramp pain in the leg, thigh, and the buttock with walking and disappear with rest. This is the claudication pain. It is the second point in our triad. When go to the examination, patient had no peripheral pulses in both feet, no popliteal pulses. Patient also had no femoral pulses bilaterally, and patient had a good radial and ulnar pulses who had good carotid pulse. In the investigation, Doppler show aortoiliac occlusion lesion. A CT confirmed the same lesion, and patient had elevated inflammatory markers due to the infection. After all these steps, the diagnosis had aortoiliac occlusive disease, Lerich triad, and Lerich syndrome for revascularization with correction of risk factor. When it start to the last steps, the management, patient informed with the diagnosis, asked to stop smoking, started antiplatelet, vasodilator, and analgesic. Lerich, in Lerich management, the medical management include smoking cessation, management of the diabetes, antiplatelet and statin therapy, in addition to antihypertensive therapy. The exercise program should consist of daily 30-minute walking session. Intolerable claudication pain should be the end point of each session. The program caused improvement from 50 to 200% in walking distance. A traditional surgical procedure for aortoiliac occlusive disease are aortoiliac endarterectomy, aortobifemoral bypass, X-bifem, it is extra anatomic technique, and angioplasty with without stenting. Other novel methods include syrup. Aortofemoral bypass is the most preferred technique due to its long-term patency. Approach about 90% at 5 years and 80% at 10 years. The long-term patency of surgically repaired vessel in aortofemoral bypass has recognized as superior to endarterectomy and BTA with or without stenting in surgically fit patients. According to task 2 classification, Lerich syndrome is a type D lesion and recommend surgery as a treatment of choice. Again, to our case, once a patient stopped smoking and started medical treatment, pain decreased in few days. 2 options of revascularization discussed with the patient with its cons and pros, aortobifemoral bypass versus endovascular stenting through multiple axes, and patient preferred the endovascular intervention option. We do our angioplasty through left transbrachial access to the aorta. The right iliac lesion passed easily, as we are seeing. Then we pass through, we access the left femoral from the retrograde approach. Bilateral balloon mounting kissing stent from the double axis inserted and inflated in the same time under angiographic control.
One minute to conclude. Yes.
Okay. This is our final result. This is final result with the kissing stent in the bifurcation. The bilateral pedal pulses felt at the end of procedure with no access hematoma. Under ankle block debridement of the necrotic tissue and the infected bone, patient walk freely without pain and experience a good maintained erection during intercourse due to good revascularization to his pelvis through patient iliacs. This is the photo 1 week later and 2 weeks later. I decided to suture the wound under local anesthesia, but the patient refused and missed the next follow-up. But no news is a good news, and I hope he continue his medical treatment and stop smoking to maintain his stent patent for a longer time. This is our angiogram pre and post, and this wound pre and post. And thank you.
Thank you, Dr. Amr.